Hey, I wanted to introduce Dr. Troy Henning and a big thank you to Ann Taylor for her introduction to the two of us. And Troy, you may have seen him on a couple of our blog articles that we had posted over the last 2 months. So if you haven't had a chance to read those, go back and read them. Just a great addition to the Swedish team, and not only an addition, but is now running the sports medicine performance group as well as the diagnostic ultrasound. And he might talk a little bit more of that at length at some point. But originally from Pennsylvania, attended the Philadelphia College of Osteopathic Medicine. Has had some great work, both with residency at the University of Washington and a fellowship at the world-renowned Mayo Clinic. And at this point, it's just exciting to have you here and talk about one of the things that I think we deal with as physical therapists all the time, and that is tendinopathies, Achilles, elbow, between CrossFit, running, hiking. These are things that we are showing up in our offices daily. And it's great to have another expert that can have different strategies to treat these. So without further ado, I'll welcome you there. And I appreciate everybody for attending, and stay tuned. At the end, we'll have some question and answer. So you can, the housekeeping component is you can submit questions via the comment section, and I will take those and we'll compile those for Dr. Henning to answer at the end. So I will let you take it from here, Dr. Henning. Thanks.
All right, well, great. Thank you, Ben. It's a very nice introduction, and thank you again for inviting me to join your team here. It's always great to meet our partners in the community, and I'd like to also thank your colleagues at Lake Washington Physical Therapy. You guys always do a great job with our patients. So today we're going to discuss updates in the pathophysiology and management of tendinopathy. As Ben was saying, I'm the medical director here for a sports medicine group at Swedish. I also help to oversee the diagnostic musculoskeletal ultrasound for Swedish. I practice here in Ithaca, as well as have a clinic at our main site at Cherry Hill in Seattle. I have no disclosures. The goals of this talk will be to talk about tendinopathy, some of the terms related to it, a little bit on the prevalence, as well as the etiologies of it, and then focus mostly on diagnosis and treatment approaches. So most of us have heard of the term tendinitis, and this really implies that there's inflammation of the tendon. And this is a term that's still used to this day, but really it's a misleading term. Most tendon injuries are not inflammatory in nature. And so the terms below tendinosis and tendinopathy are the newer or more current preferred terms to use. So tendinosis means that the tendon has started to break down or degenerate, and there's characteristic changes within the tendon that would allow us to make that diagnosis. Tendinopathy is really the clinical term that we use when we're discussing a diseased tendon, and it's not necessarily referencing a specific cause of the problem. It's just a damaged, painful tendon, and that's the term that we use primarily in clinic. The very common injury, it's one of the more common reasons that I would see a patient for. It can involve any tendon throughout the body, but commonly in the foot and ankle region, your plantar fascia or Achilles tendon. Around the hip, you have the gluteal tendons and hamstrings. The knee, primarily the patella tendon, on occasion the quadriceps tendon, and then the elbow and shoulder. Most of them are occurring in our patients that are middle-aged, so 40 plus years old, whereas the patella tendon tends to be a slightly younger population. I think this diagram here is a good representation of how complex the cause of tendon injuries are. Starting on the left side, most people have a repetitive kind of overuse injury that's occurring where they're not necessarily aware of the problem they're creating. It could be related to a regular kind of exercise routine or work environment. And then there's a sudden change in that routine, and that leads to a more breakdown than repair process. And then it might proceed to the right of this chart. There may have been a prior injury, such as a strain or injury to the joint in that area that may also predispose them to developing a tendinopathy. And then sometimes there's some chemicals in the environment, whether they're ingesting them, such as medications. There's medications that can contribute to the development of tendinopathy. And there's some speculation that maybe infections, whether they're viral or bacterial, may also cause injury to the tendon. There's probably some other factors related to the specific patient. They may have a genetic predisposition, or there may be hormonal changes. We know musculoskeletal injuries are more common in women than men, and they tend to occur right around that peri to postmenopausal timeframe. So there must be some role as far as the hormonal environment in that person goes. Extrinsic factors, or things that aren't necessarily related to the patient per se, could be mechanical environment, such as they're unable to stop doing a specific task at work, or they're preparing for some sort of event athletically and aren't able to kind of take time away. And then, as I mentioned before, there's medications that may also predispose or lead to the development of tendinopathy. Some people will be able to heal their tendons and others will not, and they'll go on to this so-called failed healing stage. And then eventually it would become painful, and that's where we would see them in clinic. There are certain characteristic changes that occur in the tendon. Most tendons are made up of predominantly type 1 collagen, which is a type of protein that's sort of a building block for the tendon. And instead of being mostly type 1, it changes to type 3. This is a weaker form of collagen and more subject to kind of breakdown. The tendons also become hypercellular, and the cells act as a sponge, so it sucks up more water into the area, and it causes the tendon to become thickened and a little less elastic, and it appears swollen in a sense. These things make it weaker and more subject to tearing or rupturing. There's also an ingrowth of blood vessels into the tendon. So a normal tendon would not have a lot of blood vessels in it. And part of the pathology here is that the body may be trying to heal it and it grows blood vessels up into the tendon. And along with those blood vessels come free nerve endings. And those free nerve endings release different kinds of chemicals. They're called cytokines that allow us to perceive pain. And that leads to this development of so-called nociceptive pain. So there's multiple changes that occur at the tendon level, and it's a more complex process than maybe we're aware of. There's certainly some risk factors that may lead to the development of it, as I alluded to before: sudden changes in intensity or volume of activity, such as reinitiating an exercise program or even preparing for a sport, such as a running event. There's some thought that Achilles tendinopathy in general can be more common in those people who are actually following a routine instead of listening to their body and maybe adjusting their schedule based on their pain or tolerance. They're trying to stick with the schedule and kind of pushing through the pain, and that can lead to further breakdown and not giving it enough time to kind of repair itself. As with other musculoskeletal problems, being too heavy for your size places undue stress on the tissue and can lead to overloading of it. And then, as I discussed previously, certain medications, specifically statins, antibiotics, or fluoroquinolones specifically, as well as corticosteroids, primarily those that are injected in adjacent tissue to the tendon, can all lead to further breakdown in the tendon tissue. The diagnosis is really a clinical one. It's based off mostly taking history from the patient, where they'll talk about the area feeling tight or stiff. It'll be painful to engage in activity. Stretching it will hurt, or even compressing on it, such as walking or laying on it, etc. It should hurt when we examine the patient, when we push on the tendon or stretch it, or get the patient to contract a muscle that's connected to the tendon itself. We use imaging to help confirm it. So radiographs or x-rays, we can see characteristic changes on the bone where the tendon attaches to, where we look for irregularities or enthesophytes, which is a fancy term for a spur. Ultrasound allows us to look at the soft tissue quite well. It's about 3 times the resolution of MRI. And when we're looking at a tendon for abnormalities, we're looking for hypoechogenicity or darkening of the tendon. It may be thickened, and then there may be tendon tears. So I liken tendon problems to plywood. And as plywood gets wet, it would kind of become swollen and then sort of delaminate. And so that's sort of what we see on imaging as well. In addition, ultrasound allows us to look for blood flow in the tendons. As I said previously, there's this ingrowth of blood vessels, we call it neovascularization. And so we can see that on ultrasound imaging. MRI is probably a more commonly thought of imaging modality. It again allows us to look at soft tissue. Here, we're primarily looking at the water content in the tendon. And with the tendon being abnormal, there'll be more water content. So it'll sort of light up or glow on the MRI image. This top left image is a radiograph or an X-ray of the hip. This part here is called the greater trochanter, and it's where our gluteal tendons would attach to. It should be smooth, and if we look closely, we can kind of see this raised area here, and that's called an enthesophyte, and it's really a manifestation of too much tension on the bone through the tendon. And so the bone's trying to respond to the excessive loading of the tendon on the bone, and we see that. And this has been found to have a high correlation with abnormalities seen at the time of ultrasound or MRI, where the tendon would look not normal. The bottom images are an ultrasound on the left and an MRI on the right. These are examples of tendinopathy at the elbow. So a normal tendon ultrasound will have a kind of a uniform appearance, so called an echotexture. It'll have stripes of tissue within it. If we look over here where it's attaching to the bone, we can see that it's darker here. And this is what I mean by hypoechogenicity or darkness. This is filled with water, more so than the adjacent tendon. So that's why it looks darker. It could also have tears in it or clefts. So if I was to squirt some solution into this, we may see a delaminating tear open up. This is the correlative MRI to the right. It's arranged so that kind of matches the ultrasound to the left here. But here on the MRI, this is the tendon here. And you can see within the mid-substance of the tendon, there's an increased whiteness. And that's the increased water content of the tendon, signifying abnormal tendon architecture. So what are some of our current treatment approaches? Well, exercise is the main treatment. It should be the first intervention beyond modifying activities that we would have somebody engage in. And I like to break these up into my thought process into an acute injury and a chronic one, or taking into consideration athletes that may be in season or people that are in the midst of training for an event. We may treat them slightly differently. So for acute injuries or for those in-season injuries, isometrics is a form of putting stress on the tendon in a way that is not going to be too painful. It will not injure the tendon, and it can help with reducing pain and maintaining function until after their season is over, where they could focus on a more heavier loading kind of process. If they're not in season and it's more of a chronic issue, which this is the predominant kind of problem or patient that we would see, we would have them engage in eccentric loading or heavy slow loading. And we'll talk about these further. So there's a couple of studies looking at isometrics and their effect on tendinopathies in particular, primarily looking at the patella, lateral elbow, and rotator cuff tendinopathies. These were all short-term studies done over a month or so. They looked at pain and functional measures associated with the specific tendon areas, and they all showed a reduction in pain and improvement in function. So again, for these acute or in-season injuries, isometrics might be a good initial treatment tool to help that person manage the issue until they can start to address it with heavier loading exercise. Eccentric exercises have been around for a while. They were sort of first discussed in the mid-80s in a textbook describing how to treat patellar tendinopathy, and they focused on drop squats, and they would increase speed and then load and only perform it during a pain-free process. In the late 90s, Alfredsson, he's an orthopedic surgeon out of Sweden. His group looked at using eccentric loading in the treatment of mid-portion Achilles tendinopathy. And they would really load the tendons heavily and have the patient exercise despite having pain. And then they would have a goal of having the person perceive mild to moderate pain during the last couple of reps of each set. And this has been the more popular version of how to approach a tendon since that time. There's a large body research supporting the eccentric loading exercises. Most of it's focused around the Achilles tendon and patellar tendon because that's Dr. Alferson's kind of area of specialty. There's some on other areas such as the wrist extensors as well as, rotator cuff. Almost all the research that's been done thus far has been based off of Alferson's work. And their regimen consists of generally 3 sets of 15 repetitions. The exercise regimens to be performed twice a day, most days of the week, where the person would be experiencing mild to moderate discomfort during the last couple of reps of each set. And as it becomes less painful, then they would be advised to increase the load. General conclusions from the collection of these kinds of research shows that 60 to 90% of people will respond to it over time. You still need to remove them or have them modify their activities so they're not offending the tendon outside of the exercise. And it really takes a long time for people to see any kind of response to the exercise program. I usually educate the patient that if we send them to physical therapy, the role of physical therapy is really to educate them and to get them a program going, and that they will need to continue to do it outside or beyond physical therapy. Most patients are not doing the exercise at this intensity or volume, certainly maybe only once a day, not twice a day, and not every day of the week. And it really takes time to buy into doing exercise with pain. So I usually advise the patient that it will likely take 6 months of doing the exercise before they may perceive a change in their pain. There's another form of exercise called heavy slow, and this is more traditional kind of strength training where there's a part where you're flexing and extending the muscle. It's a simpler kind of biomechanical way of strengthening. And so there's this study where they compared heavy slow versus eccentric loading for the mid portion of the Achilles. The heavy slow regimen was performed using both legs, not just a single leg. It was performed 3 days a week over 12 weeks, so not every day. And they only did 3 to 4 sets of the exercise. They would start with high volume but low weight, and then as they would progress down over the course of 12 weeks, it was less reps and more weight. And then the eccentric exercises were performed unilaterally, and they followed the standard Alfredson protocol. For the exercises, specifically the heavy ones, they focused on using the soleus press, the leg press, as well as the Smith machine, targeting the mid-portion Achilles tendon. And they followed them using pain and functional measures for the Achilles tendon over a year. And they saw that both groups improved without any difference between the outcomes. However, when you look at patient compliance with exercise, the heavy slow group was more compliant and they were more satisfied throughout the course of their treatment. And so I use this when I think about which exercise regimen to help people learn how to do. I think the heavy slow program is simpler from a biomechanical standpoint. It's more feasible given the volume of exercise that you need to do at one time, as well as through the course of a week. I think it's just more realistic. This group looked at how heavy slow loading may affect the tendon properties. So they looked at the patellar tendon specifically and put them through the heavy slow loading regimen that we just discussed. And then they compared it to a control group. So they took subjects that had a normal patellar tendon. Prior to the intervention or the exercise, they took biopsies of the tendon tissue, and then they repeated this at the conclusion of the study. Importantly here, there's a couple things. They found that both groups had a similar mechanical property to their tendon. So this tells me that when a tendon is not normal or it's tendinopathic, we can load it heavily without fear of causing injury to the tendon. And I think that's helpful for the patient to know as well. They're always afraid that if they're loading it too much, they may rupture or tear the tendon. And I think this is one study that can help show that that is unlikely. Additionally, the heavy slow loading exercises caused an improvement in the architecture of the tendon itself. So it's actually healing the tendon. So I think this study helps answer 2 important clinical questions that I get asked every day. Here's some of their histologic studies. So this is a slide of the tissue. They're looking at it under a microscope. And these are round things here. These gray round things are the tendon fibers themselves. They're swollen. And then after the exercise routine was completed, you can see the tendons fibers are a more normal size. So they're round, smaller round, and they're more tightly packed tendon fibers here. So this is more normal architecture. So that's the flavor of the types of exercises that we would typically recommend. There are some medications that we can use for helping control the pain during the rehab process. You may commonly think of using Tylenol or NSAIDs such as ibuprofen and Aleve, and those are still commonly recommended. However, you may not have heard of using nitroglycerin patches. This is a heart medication that we use in an off-label sense to help with pain and maybe help influence healing. This was discovered in an animal model, so they looked at rat Achilles tendons, and they were trying to investigate how tendinopathies occur and what's going on in that environment. And they found that there were different forms of this enzyme called nitric oxide synthase. It makes nitric oxide. And in our bodies, nitric oxide is a chemical transmitter. It turns on and off different processes in a cell. And they were able to grow a rat that did not have this enzyme. And when they looked at the tendons, they found them to be smaller and they were weaker. They failed at a lower load. And then they took the same kind of rat and fed them nitric oxide or nitroglycerin, and then looked at the tendons, and they found that the size of the tendon was more normal, and it had a better integrity or biomechanical strength. So normalized the tendon. And the Murals group has done the bulk of the research on patients or humans, and they look at using this in a variety of different areas about the body. This is done, these investigators live in Europe, and so they have a slightly different formulation for their patch. And so they studied it at the elbow, the rotator cuff, and the Achilles tendon, and they compared the nitroglycerin patch use to a placebo patch. They had both groups perform non-specific exercises to strengthen the region, and they found that in the nitroglycerin patch users, they had a reduction in pain and an improvement in function at about 6 months out from the initiation of the medication. I use this commonly as my first line medication intervention. In addition to the exercise routine, I think it's a nice adjunct to the exercises. Here in the US, we have 0.1 milligram per hour. And so I have them take a full patch and place it over the painful tendon somewhere in the region. And they're just simply changing it daily for a new one. After about a week of two of using one patch, if they're not experiencing enough relief, they can progress to using 2 patches. And that's why I find the bulk of patients would be responding to it. The medication is simple and safe. It does not harm the heart or cause injury. We don't have to check labs and those sorts of things. It does have the potential for side effects, most common being headache, which could be very mild to intolerable. So obviously, if it's a horrible headache, we would have the patient not use it. If it's not horrible and they can kind of hang tight with it, the headaches do generally go away. And if it's working, then I usually recommend the patient stick with it for about 6 months, because that's roughly how long I think the exercises will take. Moving on to injections or procedures, steroid injections have been the mainstay of treatment for pain for tendon issues for a very long time, mostly because I think people thought they were inflamed tissue. And as we discussed previously, they're not really inflamed tissue. And while they've been used for a long time, they may not be the best choice. This systematic review performed by Coombs' group back in 2010, they looked at the safety and efficacy of steroid injections used in the treatment of tendinopathies. And they compared it to other kinds of injections. So this kind of graph is called a forest plot. The dark vertical line here, or the 0 line, is called the null line. And in general, anything to the right of it would favor the cortisone injection. Anything to the left would favor the other kind of intervention, so not the steroid injection. And they broke it up into short, intermediate, and long-term studies. So in the short term, which they defined as 0 to 12 weeks, the steroid injection worked better than any of the other interventions in general. And I can say that's pretty much the case in clinical practice when I do a cortisone injection. patients will often get 2 to 3 months of relief of pain. But looking beyond that 12-week period, you can start to see that the steroid injections become less favorable and the other interventions may be more effective. In addition, the steroid injections could be potentially harmful. As we discussed, it could cause or worsen tendinopathy. And so the same group performed a randomized controlled trial looking at using corticosteroid injections as well as physical therapy in the treatment of elbow tendinopathy. Another forest plot here. So again, anything to the right of the vertical line would favor the steroid injection. Anything to the left would favor the other intervention. So the other intervention was a placebo injection. And again, you can see in the short term, so 4 weeks to up to 26 weeks, the steroid injection had a better response as far as reducing pain. But at long-term timeframes, the placebo injection was more effective. This study looked at the risk of steroid injections as they relate to increasing the potential to having a repeat surgery. So they looked at the use of steroid injections around treating tennis elbow. It's referred to as lateral epicondylitis. And they looked at the risk factors for patients that had to have a second surgery after their primary one. And the one factor that was putting the patients at most risk was having more than 3 steroid injections in the region. And this has been shown in the plantar fascia region as well. So, if I do a steroid injection, I'm usually recommending only 1 or 2. I make it understood that it's really for short-term pain relief, and it's buying a window by which maybe the patient could engage in exercises more effectively. And that really doing too many of them is probably the wrong thing, and we would need to reach for a different tool at that point. Corticosteroid injections, they injure the tendon by this mechanism. So they increase this receptor called NMDA, and that allows an increase in calcium to come into the cell, which is really the grim reaper for a cell. So an influx of calcium leads to cell death, and that is the same process that occurs in any cell throughout our body. And so it actually can kill cells. So it's not that benign of a medication. You may have heard of platelet-rich plasma injections, or PRP injections. This is a way of harnessing our own body's innate immune response system to try to help stimulate a healing response. It's been used in medicine since about the 1970s. They initially used it for treatment of thrombocytopenia, which is a low platelet count. And then in the 80s, they started to investigate its use in and around the face and jaw for bones that were not healing properly. And then they since have been utilized in a variety of different areas, but heavily in musculoskeletal sports medicine as of the past, let's say, 2 decades. We get it by taking blood out of someone's arm. So we take venous blood. It goes into a kit, which is basically like a apparatus that holds the blood, and then it pushes it through a machine called a centrifuge. It basically spins the blood at a high rate, and that helps separate the cells from the fluid part of the blood. And then we're able to collect the different layers of the cells and some of that fluid in a very specific way. And we're generally looking to concentrate the load of the platelets, aiming for somewhere greater than 5 times the circulating concentration of blood. So more than 5 times what's in our blood normally is what we're going after. There's different ways of making it. We can make it with more white blood cells or less. It's thought that using a concentrated form with more white blood cells may be better for tendons, whereas if we use it in a joint, lower white blood cell count may be more helpful. Why do we want to use the platelets? Well, these are basically envelopes that float around in our blood. And when you have an injured illness, they will come and release their what we call growth factors. And these growth factors stimulate our immune response system. They help break down the damaged tissue, and then will stimulate a healing response. At the cell level, they help turn on and off different processes and kind of stabilize or make the environment more normal, kind of homeostatic. That helps balance out inflammation and pain. And then there are cells in our tissue called stromal cells. whether throughout our body, whether they're in a joint around a tendon. And these are our local stem cells. And so we think that some of these chemicals will help turn on those local stem cells and engage them and get them to heal the tissue. There's lots of research on using PRP for tendinopathies. The point of showing you this very busy slide isn't to overwhelm you, but to show you that it's been studied at a variety of different regions around the body. Most of the research has been done within the past 7 years or so. Level 1 and 2 studies are very high quality studies. These are usually comparing one intervention to another. In level 1, there would be some blinding, meaning that the person doing the procedure as well as receiving it have no idea what they're getting. So that would be considered a good study and helpful to make informed decisions. You'll see here that most of them have a fairly low number of participants in the study. And so a lot of them are what we call underpowered, which makes it hard to differentiate what is actually going on sometimes. There's a lot of what we call heterogeneity in the studies, meaning different ways of looking at the same thing. And so, like I said, sometimes people are using leukocyte-rich or poor forms of PRP. And the other thing that they're comparing it to may also vary. So some studies looking at a placebo injection or some kind of anesthetic or steroid mixture injection. And then they're following up these on these subjects at a variety of different time intervals. So it makes basically comparing all this information, all this data, very hard because they're not necessarily apples to apple comparisons. Nonetheless, if you look, there's about 15 positive, meaning the PRP intervention worked, and about 9 negative studies, meaning it did not show any effect. This is another systematic review, again, another busy slide, but it looks basically at the pooled effect of PRP over time. So at the very top, it's basically prior to the injection. And at the very bottom, it's about 2 years out from the PRP injection. And you, again, it's another forest plot. And so in this case, anything to the left of the vertical line would be an improvement or reduction in pain. And so you can see over time that after the PRP is injected, right around the 3-month intervals where patients start to perceive a significant reduction in pain. And then this would continue out to about 2 years of data points that we have here. And this is what we would typically see in our clinical patients as well when we use this in our current practice.
If I can interject real quick, Dr. Henning, I'm a PRP on a left severe meniscus tear. It was a scheduled surgery, and I don't know if it's probably not captured in the literature at this point, but it was kind of an interesting thing of the rehab component as well. And even as a physical therapist, I took my rehab much more seriously once I had paid cash to have a PRP injection. So my compliance was very good. I'm at about the 2.5-year mark, so falling in that same timeline of that last chart. And so for me, it was super successful. I was able to keep all the meniscus. I have not had a post MRI of the procedure, but I think the pain reduction and the consistency seemed to work for me. And I think it's worked for a fair amount of my patients too. So it's I think preferable versus removing large chunks of the meniscus, at least as a try, if you have the budget and the time to attempt it.
Right. Yeah. It is a type of treatment that by the FDA standards currently is considered to be experimental. And so that implies that insurances are not covering it. So it is something that people would have to pay for traditionally. There is one insurance so far in the US, it's TRICARE, and they are covering it for indications related to knee arthritis. It has to be mild to moderate knee arthritis. And they're covering it for lateral elbow tendinopathy or tennis elbow. So there are some insurances that are looking at it closely and making different choices as far as what they're going to cover and not cover. So hopefully we as providers that are doing it can be better about doing good research and show or support that it is effective. Our group is currently doing that. We were blessed with a very nice donation that's going to allow us to press forward with research in this area in particular.
Well, I mean, I think too, just my conversations with payers over the last couple of years too, I think almost if I was a payer, I would almost require a PRP before I would pay for a $20,000 surgery of the knee, just as an attempt to do it. So
Yeah.
I thought it was a great procedure. It's something worth exploring for people. And I think just to Dr. Henning's point too, not to get you off track here, but I think like for so many patients of ours, they do have an HSA, a health savings account, and that is something that you can put pre-tax dollars into. If this is something you think you might be interested in, whether it be shockwave, whether it be PRP, whether some of these other regenerative medicines that aren't currently covered, I think there can be some great avenues where yes, you're paying cash, but if you do put money away in HSA, it's something you can use really easily, and it could be have good efficacy in your care. So,
All right. Exactly.
sorry for.
Oh, those are all great points. Yeah, I think of all these steps, medication beyond in what I'm giving you here are all adjuncts to exercise. So I always start off with exercise, even if someone's done exercise or had physical therapy in the past, and maybe it's been a while since they were performing their exercises. I always like to start fresh because I think without the exercise part, these other things are not going to work as well. So there's not too many things that I can do to somebody or anybody can do to somebody that's going to cure them, that they're going to have to be a big part of that treatment plan. And that's where exercise is really helpful. So moving on to another treatment modality essentially is extracorporeal shockwave therapy. And there's different types of this. Most of them are done with a version called focused, and a newer one's called radial. So focused type allows the practitioner to provide or give the shock wave or impulse at a very predetermined depth. It's one that's used most commonly. It's been most studied. And then the radial is somewhat newer technology. It uses more of a pulse rather than a true shock wave. It doesn't penetrate as deep, and so it may not be for deeper structures. It may be more beneficial for wound healing. Because it's new, it has fewer clinical indications as well as fewer research studies supporting it. There's different types of what they call generators or devices. Some of them develop the shockwave via electrohydraulic means, magnetic or piezoelectric, which is a conversion of electrical energy into sound wave. The thought is that these shock waves penetrate down into the tissue and they'll cause it to kind of vibrate or cavitate, and that will cause a local tissue injury, and that would then cause bleeding, and then try to get those platelets to release those growth factors, such as we discussed with the PRP injections. And it's been performed in research in a variety of different regions around the body, with some evidence showing that it may be an effective tool compared to other interventions, whether it be steroid injections or exercise. Again, it's a relatively newer technology, and we do not do this, but I'm of the understanding that it is not something that's typically covered by insurance, and therefore maybe cash pay, or you could use your health savings account for that. It is something that can be a bit challenging to undergo. It can be painful. Some providers that do it think they don't need to make it painful, whereas others think you need enough energy in order to cause some kind of positive effect, and that would translate into it would be a painful process, albeit short-lived pain, and then it's something that would be done on a repeated basis. So it's not just like a one-time treatment. You're going in for several treatment sessions over a span of time. The next intervention is percutaneous ultrasound tenotomy. It's using a specific device to do the procedure. Tenotomy is defined as a division of a tendon, and traditionally it's been thought of as using it to lengthen a tendon, such as in a region where someone would have a tight tendon that would cause limitation of motion at the joint. The tenotomy that we do, we use this device called Tenex, and it is used to debride or remove and cut the abnormal tendon tissue out of the body. It works by a mechanism called phacoemulsification. It basically liquefies the damaged tissue using an ultrasound wave. And then it has some mechanism by which it circulates some saline through the area to help kind of lavage or wash that non-normal tissue out. And you may ask or think, does this really work? And that's what I would ask as well. And so here's a study where they studied it in a rabbit Achilles tendon model. They basically had 3 different types of rabbits. They kept one as their control or their normal. And then in 2 others, they injected this medication called collagenase, which is a medication that can dissolve tissue. And it basically replicates or induces a tendinopathic model. What is happening? A normal tendon has predominantly type 1 and type 10 collagen, and an abnormal tendon or tendinopathic tendon, like I said previously, has more of a type 3 collagen in it. So of the one of the 2 tendons that they treated with the collagenase, they treated using the 10X device. And you can see after a period of time, they sacrificed the rabbits and looked at the tendons again and found that the treated tendon with the 10X had a better amount or a more normal amount of collagen type 1 and type 10 and less type 3. So it is causing some sort of normalization of the tendon architecture, at least in the rabbit. Others might say, is this actually able to remove tissue? And so this study used a cadaver model where they performed it on 2 patella and 2 quadriceps tendons, and then looked at the tendons after they performed the study, and they found that they were able to effectively remove the tissue in that target area, and also importantly that the adjacent tissue near where they were working was not injured or damaged. So it is effectively cutting out the non-normal tissue, and it is also stimulating some sort of normalization within the tendon. These next slides here show what's been reported in the literature, not to exhaust it, but just some examples. So Hall's group out of Iowa released this case series on using it for insertional Achilles tendinopathy, which is a very problematic area. It's resistant to a lot of different forms of treatment. And they showed that was able to reduce pain, and the patients were very satisfied with the results or outcomes in the majority of those that were treated. They did report one complication, which was a soft tissue infection kind of at the skin level. So nothing that wasn't, nothing that required anything more than some oral antibiotics afterwards. Another study looks at using it for the treatment of calcific tendinopathy about the shoulder. So we can use it in the upper body, as well as in deeper tendons such as the gluteal tendon. In practice, we'll use it around the shoulder, the elbow. In the hip area, we'll use it for the gluteal or hamstring tendons. Around the knee, it's predominantly patella tendon, but you could use it for the quadriceps tendon. And in the lower leg, it would be for the Achilles tendon, whether it's the mid portion or insertion, and for the plantar fascia. There's this long-term study where they looked at the results when they used it in the treatment of tennis elbow or lateral elbow tendinopathy, and they followed the subjects out for 3 years after the treatment. And they found through that period of time that there was sustained improvement in pain reduction and improvement in function, as well as a normalization of the tendon architecture when they looked at it at that 3-year interval with ultrasound. This comparative study looks at the use of PRP compared to 10X or tenotomy for elbow tendinopathy, both medial and lateral. And the patients were basically chose the treatment option that they wanted. And they looked at pain and function scales in following the patients. You can see both the PRP and 10X pre-procedure pain was fairly similar, and they both showed a significant reduction in pain at the conclusion of the study or the follow-up period. And both groups showed an improvement in their function. There aren't really too many studies that I'm aware of where they're looking at this in a blinded fashion, or maybe in a fashion of doing 10X and then following up with a PRP. So there's some of these things are occurring in the treatment of patients currently that there isn't a lot of evidence for, but in the right patient or indication may be beneficial. This is some of our data. So we'll collect pain and functional measures on patients when we do these procedures. So looking at use for tennis elbow, you can see that over time, specifically around the 12-week mark, there's a significant improvement in function, and that continues out as we follow them out over the course of a year. And you'll see a similar pattern with plantar fascia, where around that 12-week point, after the procedure, their function's improving and their pain is reducing. Similar with the patellar tendon, again, at the 12-week point, kind of improvement in function and a reduction in pain. And so this is how we educate patients on expectations after the procedure, in the sense that it may take 12 weeks afterwards to see any kind of profound improvement. This video here is demonstrating the procedure. So it's an ultrasound guided procedure performed through a small incision in the skin. The device is placed into the diseased or non-normal portion of the tendon. It then creates this sound wave that kind of liquefies the non-normal tendon tissue. And then it's pushing in and sucking out saline that helps kind of wash out the non-normal tendon tissue. This is all done in an outpatient setting. We thoroughly numb up the region. It's really a well-tolerated procedure. These are some ultrasound images of a scan of a lateral elbow prior to doing the procedure, and then showing the procedure being performed. Prior to the procedure, you can see all this abundant blood flow in the tendon. Again, that's not normal. And then under ultrasound guidance, we're able to guide the device into the correct portion of the tendon. Here's what it looks like being performed at the Achilles tendon insertion. And then on ultrasound image, you can see the device in the tendon, removing the non-normal portion of the tendon, as well as targeting that calcification in the tendon. This is an example of a patient with a runner with jumper's knee. And this is an MRI showing the damaged tendon here, and its correlative ultrasound image on the right. Again, there is a lot of blood flow that's not normal within the tendon, and this would be the region that we would target with one of our interventions. This is the ultrasound image of that tendon prior to the 10X procedure. And you can see down here, the tendon looks kind of more spongy. There's not a lot of striations or fibular pattern to it. It's also darker. And this is about 3 months after the treatment, where you start to see more normal fiber architecture, has more of a striped pattern to it. And it's not nearly as thick as it is prior to the treatment. And this patient had a good response as far as reducing pain and improvement in function, and they were able to get back to running. So in summary, tendinopathy is a very common musculoskeletal injury or a problem that we see. It's not necessarily age dependent. We see it across a spectrum of ages. We think it's due to some failed healing response, and there's different factors that may play a role that may be related to the patients themselves or their environment. The vast majority of people respond to exercise, one form or another, and this is somewhat dependent on the practitioner and the patient, how we're going to treat them. Corticosteroids are really a temporizing measure. They're going to work for a period of time and they'll stop working, and too many can be harmful potentially. And then newer procedures such as tenotomy or PRP, there's other things that we do that I didn't go into detail today, but there's new things that are coming out all the time done in a way to try to help heal the tendon, not just mask the pain. And these are really adjuncts to the exercise. I've included some references here at the end that weren't necessarily included on the respective slides that I presented before. So again, I appreciate this opportunity, and I hope this was helpful learning.
Absolutely. It's great, great content. Very, very, oops, hold on, let's see. Let's put you back on there. Anyhow, I've got a couple of questions that have come in. Again, great content, and I think it's exciting. This was tailor-made for PT. This should be must watching for sure. Quick question on your favorite kind of approach when you have a plantar fasciitis patient show up, because this is obviously going to be running rampant here real soon as everyone gets outside and starts walking and and being out and running and in lighter footwear usually. Granted, there's a lot of variables, height and weight, everything goes into it, but typically like for an acute versus a chronic, what are your typical approaches you like to kind of hit first?
Well, first, you have to modify the loading across the region. So usually that means, changing their mode of exercise. If they're a runner, maybe looking more towards biking or swimming, or maybe elliptical if they can tolerate it. Maybe using a stiffer soled shoe, or integrating use of a carbon fiber plate into a shoe to make it stiffer. Hiking boots or shoes are often stiffer, so that makes it a little bit more tolerable because it's not stressing the fascia every time they step on it. Sometimes just a simple shoe insert that helps kind of support the arch and off-weight the fascia can be effective. I like to use a plantar fascia night splint or a Strasbourg sock as well, because often these will be associated with a tightness in the heel cord or the Achilles tendon. So that helps to manage that aspect and get that stretched out. And then starting off with strengthening exercises for the foot intrinsics. So your typical kind of marble pickup or cow curls, etc. And then aggressive stretching of the plantar fascia and Achilles tendon to try to lengthen those structures so they're not being overly loaded.
Yeah,
Those would be
that's
my
all
typical
great.
for all like acute or even like chronic ones. And sometimes they've tried that in the past and they've sort of gotten away from it, but I try to really enforce that that's really the crux of the treatment.
Right. I think that's a great preventative stuff as well. Like, so as you start to, if you know you're going to start ramping up mileage, you're going, that's probably not the case this summer, but normally like my patients go to Europe, they're going to do 10 miles of walking and they've been doing 1 mile of walking. All of a
Right,
sudden, a major volume, like you said, loading increase.
right.
Even if they're thin, it's still a large load increase on the total volume of foot striking and standing that they're doing a day. So I think that's good advice. Do you have a protocol? This is sent in from a couple of PTs. Do you have a protocol that you like for a PRP, like rehabilitation setting?
Yeah, that's it's still a bit of the wild, wild west as far as how people do these things. We just had our sports medicine national meeting last week, and that exact question was posed by the doctors that do these things. And there was a group of us, a panel, and all of us had somewhat of a similar kind of answer to that. So it's not an exact thing, but it's again just using the tissue healing model as our way of really guiding us. And so we know the first few weeks there'll be this inflammatory response. And then somewhere around that 6 to 8 week period afterwards, it'll be safer to load it more heavily. So maybe in the beginning, we sort of protect it a little bit, modify the activities, look more towards non-weight bearing modes of aerobic exercise, maybe doing the isometrics or very graduated kind of isotonic exercises, and then progressing gradually to that heavier loading somewhere around the 6 to 8 week point afterwards, and then aiming to get them back to a target activity somewhere more around the 12-week interval afterwards.
I think that seems super reasonable. And that's kind of what I did to myself as well. So it was helpful. On iliotibial band syndrome, because this is going to be poking up into your office, probably already has today. What are your approaches? I mean, there's still some things that are going to be similar to plantar fasciitis, but are there things that you like specifically for, kind of quote unquote iliotibial band syndrome?
Right. So, whether it's at the hip, I guess you could rub at the hip there and cause snapping hip, or it can rub at the knee as it passes the lateral, we call lateral femoral condyle there. It's a whole kinetic chain, a lower extremity kinetic chain problem in the vast majority of people. They'll often have dynamic valgus on single leg squat. They may have pes planus on that side, something that's causing internal rotation and adduction of the hip and a valgus angulation at the knee, kind of tensioning the IT band either across the trochanter or the lateral femoral condyle. And it's going to cause rubbing. Some people have thought that there may be a bursa between the IT band and the lateral femoral condyle, and that has not been proven in more recent anatomic studies. And really what's due to the IT band there is just the joint capsule of the knee. And so they're basically creating a synovitis, which is going to create an effusion in the knee. And now there's going to be even like a tighter space rubbing between the femoral condyle and the knee. And it turns into this a vicious cycle. So it's really, you got to attack it from both the foot and the hip level, improving their neuromuscular control, their pelvic girdle strength, hip control, and then looking for those muscle length imbalances at the IT band around the hip and the Achilles tendon area to try to normalize the mechanics. During that process, if you're a runner or they are a runner, again, modifying activities is going to be the key, getting that friction biomechanical problem to calm down. Otherwise, they're just going to continue to rub it and sort of just kind of bang their head against the walls with that.
There's a lot of head banging for sure. And Dr. Henning had a great assist on the article that we recently had on our blog about medial patellofemoral syndrome, and he has some great quotes in there too. So that's worth checking out as well. Any words of wisdom? Final question here. I don't want to keep you all day, and appreciate the time.
Yeah.
CrossFit athletes on increases as people return back to the boxes here, on how much that they do, how quickly, especially for folks that are, say, our age, where they've been sitting in front of a Zoom camera at Microsoft or Google for months, and all of a sudden you're going to hop back in the box.
Right.
Do you have any general guidelines there?
Yeah, I think you got to approach it methodically and not get caught up too much in the pressure, peer pressure, if you would, of pushing it hard and fast right away. I think starting off, again, looking at simple biomechanics, maybe just using body weight and really focus on the slow controlled motions as opposed to the elliptic ones, avoiding the plyometric things, box jumps, etc. I think with CrossFit, I mean, at least it's engaging people and getting them to exercise, so that's a really good thing. But I think you really need to have a sound understanding of how to lift properly and be able to withstand the loads and the intensity that maybe the class or that group is working on. And if you're not ready for it, I think you just need to be honest with yourself and work at your level. And I think the participants as well as instructors would respect that and hope that you do that. Because most of the time when I see injuries, whether it's because of a pandemic or prior to it, it's almost always been too much too fast, trying to test themselves in a way that they're suddenly trying to max out, right? And they hurt themselves that way. So
I think that's sound advice too. I think the competition is what we usually see gets people, and that could be even in the Peloton world. Like you get the AMRAPs, as many reps as possible, and I think that's when you usually see it's a form failure.
Mhm.
And there is a great workout there inherently, if you survive it. It's kind of a Darwinistic AMRAP sometimes are, but I think if you have good instructors, you're in a good box. I think it's like, to your point, I think having sound instruction early on leads to not being in our offices later.
Right. I mean, I think that it employs some mostly closed chain exercises, which I think are helpful and a good way of strength training in a functional way. And it could help you engage in a lot of variety of different kinds of sports or activities and be protective that way. But I think too much too fast and the not ideal or less than ideal mechanics are where people get injured.
Yeah, absolutely. That's probably good advice for every sport and activity, really. Hey, I want to really thank you for the time. We really appreciate your expertise here. I'll have information on how to get in touch with Dr. Henning in the show notes, as well as on our YouTube channel. Excuse me. So you can always reach him through Swedish, but we'll have more information about him in there. If there's anything else you need in the future, let us know. Otherwise, we really appreciate the time.
Yeah, you're welcome. It's my pleasure. It's a great opportunity. I really appreciate it. And hopefully I can help in the future.
Awesome. Hey, well, thanks. And thanks for everyone that's attending. I appreciate it.